couple rooms away. Do you hear anything now?
No, I did hear that.
That was you.
No, I don't.
You
Oh,
don't?
that was mine? Huh. But I don't hear her at all. So
Okay.
yeah, we're totally good.
Okay.
All right. Well, let me start again here. We are just so very grateful and honored to be able to have Dr. Mitch Scheimann here with us today, the man that actually wrote the textbook that I used in my very first vision therapy class. So welcome, Dr. Scheimann.
Oh, thanks very much, Ben, for inviting me to do this.
Yeah, we're excited to have you. I'm sure I don't really even need to introduce you, but I will. Dr. Scheimann is a renowned lecturer and author and researcher. He's most known for his seminal research, including correction of myopia, evaluation trial, numerous studies on amblyopia treatment, and of course, the National Eye Institute funded randomized double-blind multi-center placebo-based convergence insufficiency treatment trial. And then, of course, the follow-up study, which was the CITT attention and reading trial, which we'll be talking about today. But first, if I can give a little bit of a personal anecdote, it was one of my very first COVD meetings when you got up to talk about the convergence insufficiency treatment trial. And I remember thinking after that, wow, I am so fortunate to be in the golden age of vision therapy. We now have gold standard research showing that vision therapy works. So I think our profession owes you a huge debt of gratitude for all the work that you've done.
Appreciate that, Ben. It's been a long haul. When we first started talking about doing these studies, it was way back in the about 25 years ago. We had no idea. I think if we knew how much time and effort this was going to take, it may have dissuaded us from even getting started. But we've made it through. And done multiple studies over the years, but it's been much more effort than we any of us imagined it would be.
Wow, I'm sure. Before we get too much into the research side of things and specifically talking about the CITT-ART, I wanted just to get to know you a little bit more. I think a lot of our viewers would appreciate that. So, did you always know that you wanted to be a researcher?
That's a good question. No, in fact, when I graduated from optometry school, my objective, my goal was, like most students at that point, I wanted to open up a nice private practice, and I had no intention of not really of even going into optometric education, but I developed this strong interest in my third year of optometry school at Nowenco. I think many people know the name Indra Mohindra, the Mohindra method, right? She was my professor for binocular vision therapy, my third year, and it just rang a bell when I said, this is really interesting. In those days, there was no medical optometry. It was, you did refractions, you treated presbyopia, myopia, and that was about it. Now, this was back in the 70s, right? So now I have this interesting area where binocular vision, fusional vergence, you had to actually think a little bit. And it was fascinating. So when I finished that course, I quickly signed up for at that point, before SUNY was a school of optometry, they had the optometric center with all the greats, Flax and Birnbaum and Forrest and Sherman. It was unbelievable. And they had this 8-week internship program in vision therapy. I signed up for that, and that really changed my life because I'm working every day with these great names, right? I mean, we all know people. These are the people we talk about, right? And that convinced me that, okay, this is what I want to do as an optometrist. And I went into, I then applied for the residency. It was just the second year of the residency at SUNY. I was actually, the VA had a residency, and then SUNY started the VT residency. That's all there was at that time. You'll recognize some names from the first class, like Bob Sannett was in the first class, and
Okay, yeah.
Kenny Kozlov was in the first class. I think there were two more as well. I don't remember their names, but I was in the second class. And fortunately, I got in, and again, I had no intention of going into optometric education or research. I wanted to open my practice, and now I wanted to do VT, right? But 6 months into it, I started teaching students, and I said, I like that. So maybe I'll try that for a year or two. And I went back to Boston, and became part of the clinical staff there. And one thing led to another. All of us interested in VT back in those days, we were really, it was very difficult for us because a lot of skeptics, like there are today even, but very, very low level research, case studies. It was all anecdotal. And I was a young man, and I said, it's not my responsibility to do any of this. Where's Flax, Birnbaum, Forrest, Sherman, all these other guys, let them do the research. They're the people I look up to, but they didn't do it. It just never happened. And one day I looked at myself in the mirror and I said, hey, I'm not so young anymore. I could see I'm getting older. I no longer had that excuse. I was now middle-aged. And, I'd written a lot about VT, and I looked at it as now my responsibility. So without any real training in clinical research, I set up, we formed a group of people around the country that about the same age, Cotters and Rouses and Lenny Press and others. We started out and we said, we've got to do this. We're tired of hearing, show me the data. And we've just got to do it. And we learned how to do it through practice. I got my big break when it had nothing to do with vision therapy. When we did the COMET study, I was asked to be a PI for one of the studies. So I had the opportunity of working with some outstanding researchers like Jane Guazda, people know her name from COMET, and a number of others. And they really taught me how to do research. And then we applied that to CITT, and it was like doing a residency in research. Eventually, as you probably know, I went back and got my PhD just for the heck of it. I didn't really know it. By that time, I knew how to do clinical research, but I thought it's nice to have another degree. And but no, when I look back, it's the strangest thing. I had no intention of doing any of this. All I wanted to do was open my private practice and live happily ever after, a nice little practice, and go in, and, I was happy I didn't go into medicine. I didn't have emergencies and all that. And it was going to be a great life. And it turned out to be totally different. But none of this was planned. But, I love what I do. Today, I no longer, I've now retired from clinical practice. I sold my VT practice, and I don't even teach optometry students anymore. I'm a full-time administrator. Well, 70% of my time I'm administrator. I'm dean of research here at Salus University, and I run a PhD program. And about 30% of my time is still devoted to research. Wow. And a lot of the things that I want to do. So I figure I have about 10 more years of good research time, and I hope to make use of that.
I have to tell you, Dr. Scheimann, that is not exactly what I was expecting. I had thought that you must be a researcher that just found your way to vision therapy. Your research is so good that
No, it was the other way around. It was the skeptics that forced me to become a researcher. I just had enough of it, and we had to change things.
Well, I think that's really good for us younger people to think, we have a chance at maybe getting into some of this research too. So that's great.
Yeah, and I think that's absolutely true. If I could do it, anyone can do it. You start out with little things and case studies, and then you just progress to the next level. And we really need the truth of it, Ben, is we need more people becoming involved, and there are ways to do that. There, the AAO has a way to do that, to have clinicians doing research. So there are ways to get about it. And for instance, in the CITT ART study, we actually had a clinical practice, not an institution site. We had a clinical practice involved in doing research. So you can get involved, and through the PDIG organization and other organizations. So yeah, it's something that all clinical practitioners should be giving some thought to. It makes life more interesting anyway.
That's great. That's really great. One more personal question. What do you do for fun?
For fun, I'm a vegan cook. So
Really?
I've been vegan for about 25 years, and if I could retire today, I would then go to become a chef officially. So I do it as a hobby. I do all the cooking. My wife doesn't cook. I do all the cooking, and I teach some vegan cooking in my community. So that's my big hobby. So whenever I'm not doing optometry, I'm watching cooking videos and coming up with recipes and things like that. I also love sports, but my main hobby right now is so if I retire now, I'd become a vegan chef and learn how to play the flute. Those are my two things.
That's awesome. I think you were vegan before it was cool to be vegan, right?
Yeah, exactly. Yeah, I like right now. It's so easy to do it. I mean, in those days, no one was even talking about it. Nowadays, it's everyone and his neighbor is talking about. I lost this 50 pounds on a vegan diet. The athletes are talking about it. The actors and actresses. So it's really changed a lot.
That's great. Well, let's start talking a little bit about this seminal research that you've done. I think the first thing that struck me when I started to look at this research was just the amount of work that had to go into making it a valid study. Can you talk to us a little bit about that process, getting the team together, how it all came to be? I think that'd be really helpful.
Sure. Well, any of these randomized clinical trials take actually years of work. You hardly ever get funded the first time you do something like this. In fact, it took us 3 attempts to get funded for CITT over a period of maybe 8 years of work, and CITT ART. It took us it took us 2 attempts. But basically, you find collaborators who have similar interests and capabilities, and you form a team, and you have many you have face-to-face meetings, you have lots of other calls, and you have to make sure that and then of course you write the application, and it just takes hours and hours and hours. I can't even I've never even thought about how many hours those are, but you've got to kind of anticipate what the reviewers will say about each and every step of the way. Everything in the method has to be carefully thought out. All your outcome measures have to be very carefully chosen, so there'll be no criticism. Okay, that makes sense. They chose to do this, that, and the other thing. And even the best, even with 10, 15, 20 experts in a room, you end up hitting obstacles that you didn't think of, that reviewers would think about. But you're kind of trying to do good research and making up a strong protocol, and always anticipating what are the reviewers going to say, knowing that the reviewers are not going to be sympathetic generally. They're going to be ophthalmologists. And if there are optometrists, they're probably not going to be VT-based optometrists. And you have to try to see the world from their point of view. So it's a really interesting and challenging process that we go through.
So tell me about this, the team that was part. I know that it was not just developmental optometrists. So who all was in that team?
Well, this study was very different from the previous one because of the outcome measures. So in this study, we needed reading experts on the planning team. We needed attention experts on the planning team, and we wanted to make sure we had pediatric ophthalmology on the planning team. So the executive committee, the main group doing the planning consisted of all of those folks. And so we had one of the major experts in the world on attention, a psychiatrist, and he was involved with many of the. His name is Dr. Eugene Arnold. He was involved with many of the famous ADHD studies. You know, the various drugs. He was like the PI and for one of those studies. And then we had the reading person. We had Carolyn Denton, reading specialist, also well known in her field, doing randomized clinical trials of reading therapy. You know, what different things can you do, not involving vision, but just, you know, reading tutoring and different ways of trying to improve children's reading. So those were our two main experts. And then we had a well-known pediatric ophthalmologist, Richard Hurdle. We had 9 sites, and most of the sites were institutional optometry sites, but we had a private practice site. We had a children's hospital with Rich Hurdle. So it was a diverse group. We had neuropsychologists on the planning committee. So very diverse group. And you had to do that because, you know, when you apply for this kind of grant, which goes beyond just vision, you've got to show that you've got experts with experience. And so I think we had an outstanding group of planners and investigators. And in total, we had, I believe, close to 120 investigators from around the country participating in the study. And, you know, each site had to have an optometrist, a reading specialist, psychologist, you know, vision therapy person. So each site itself had to have, because the optometrist didn't do the reading testing, we had certified reading therapists doing the reading test. The optometrist actually did one test, but most of the reading tests were done by either school psychologists or certified reading specialists. So each site had to have these special investigators as well.
That's a lot of people to put together. Was it difficult to get people to come onto this project? And were many of those that were on the project really skeptical of vision therapy and the benefits?
Well, Gene Arnold, our attention person, is a great researcher, and he said, that's an interesting question. He had no bias at all. He couldn't care either way. Our reading, interesting, I had to do a little bit of arm twisting to get Carolyn to be interested in doing the study, just because she's a very busy person. But she was coming at it from a totally different place. Carolyn I remember telling me that, you know, this is a huge question in the reading field. You know, we get asked this question all the time: does vision therapy make any difference? I'd really like to be part of this. But she was a skeptic. She did not believe. And she told me from the beginning, Mitch, I know what's going to happen in the study. You're not going to find that vision therapy is any better than placebo for improving reading. It just can't happen based on the design we've developed. In my experience, it's so hard to improve reading in any way that 16 weeks of doing this, I can't imagine that it's going to help. Now, of course, that was her opinion. The interesting thing is, Ben, when I look back at it, I never even anticipated this outcome as a possibility. You know, when I look back at it, I too was biased my own way. From my 45 years of experience, I knew that we were going to have an effect. And when I actually heard the results, and of course you have to remember that as the PI of the study, as the study chair, I was totally masked for the 4 years. I did not know what the effect was, and it all came. You know, I'm sitting face to face with my statistician and the NEI person for the first time, and I'm the person they unmask, and my jaw just dropped, and you know, I didn't recover for weeks. It's like, you know, I was in a daze for weeks. It was really quite depressing for me, you know, with 20 years of work, and that was not the outcome I ever expected. But I would say the reading investigators were likely to have some doubts about this. It wasn't their field. I would say the optometrists, most of the optometrists were like me. They had little doubt that vision therapy, improving convergence insufficiency and making people more comfortable, would have to have some kind of effect versus sham therapy, placebo therapy. So we were all quite shocked and disappointed.
I think that's true. Yeah, for myself, for many that were just couldn't wait
Yeah.
to finally have this right research to be able to show that improvement. Um, for those that may not be as familiar with this study, can you tell us, just kind of summarize what the findings were?
Yeah. So let me. I wanted to shut that down so I don't keep getting the noise in the background. Okay. So the study was designed as a randomized clinical trial with masked examiners, and the patients were masked as well. So we recruited 310 children between the ages of 9 and 14. And we chose those ages specifically because we couldn't go younger than 9, because younger than 9, we didn't have a validated symptom survey. We didn't want to go older than 8th grade, because after that, in high school, no matter what you do, you can't change reading very much. So the reading specialist said, if anything, Mitch, you've got to go younger. It would be preferable to go down to 6, between 6 and 7 and 14. But we told her we can't do that. And I regret that. We can't do that because, one of the outcome measures is not possible with that age group. So 9 to 14, 310 patients. We had what we call a 2-to-1 randomization, where we had twice as many kids in the real therapy as the placebo therapy. We felt a little bit uncomfortable. Like, as you can imagine, it's always hard to randomize kids who are suffering and not doing well in school to 16 weeks of placebo therapy, even though you're supposed to be unbiased and theoretically placebo could be just as good as real. We felt, we said, okay, let's do a 2-to-1. And that's legit. It's a legitimate way to do it. So we had about 200 in one group, 100 in the other group. The kids who got vision therapy. So before they started vision therapy, we did about a 2-hour examination, which included vision testing, all the things you think of accommodative binocular vision type testing. And then we did reading testing. We also did, we excluded all kids with a low IQ. We did the KABC at eligibility to rule out kids who fell below 2 standard deviations below norm in terms of IQ. And we eliminated all kids using the RAT decoding test to rule out kids who had severe language disorders. We didn't want to include that. We assumed that those would be hard to change in VT. And I think most optometrists would agree with that the ones we can change are the ones who do have good decoding skills, and have good vocabulary, but when they try to put it all together, reading for long periods of time, they struggle. So those are the kids we wanted to include. So we ruled those out at the first visit. And where we did the eye exam and made sure they see eyes symptomatic, and we ruled out the low IQ and the reading. And then we brought them back for the reading assessment done by the reading specialist or the school psychologist. We had the Wyatt 3. We had 5 subtests from the Wyatt, I believe. We had the Gates McGinnity test. We had a test called the Ameswood RCBM and the Ameswood. These are all oral fluency, silent fluency tests. So many different tests of reading. And then we had the attention test. We had, most of you are familiar with some of the questionnaires that are used to evaluate attention. So we had a couple of those. And then we had the main one we use is called the SWAN. We didn't use the Connors, we used the SWAN. And then we used SWAN and the SNAP. And then we used a test that I'm not sure all optometrists will be familiar with. It's called the D2 test. The small letter D and the number 2, D2. And it's a test that I think most optometrists would agree is a measure of attention, where you have this sheet with very, very small print. Probably, I would say it's equivalent to 20/30 at 40 centimeters. And you have these little D's and B's, and they're backwards and flipped upside down and rotated. And you have, whenever you see two D's in a certain configuration, you have to check them off. But if they're in a different configuration, you have to not pay attention to it. And you have to try to do that as quickly as you can. And you score it on this time and the errors. So we did all that for both groups, and then they're randomized. 100 kids get randomized to placebo therapy, 100 kids get randomized to real VT. The VT that we did is exactly the same as we did in CITT. It was some accommodative work, monocular accommodative work in the beginning. We did a lot of binocular vision work, vectograms, aperture eccentric circles, things like that, a lot of flipper work. So very, very traditional VT. And that was 16 weeks of that. They would come in once a week for that, work with a trained therapist, one-on-one therapy. They would have 15 minutes, 5 times a week of home-based therapy to do. Some of it was computerized so we could monitor them. They were using HTS at home. The placebo group, and we'll probably have to talk about this a little bit more later on, were given procedures that we believed in our heart, we believed that it did not stimulate vergence any more than just reading a book would stimulate vergence. You can't not stimulate vergence to some degree. If you give someone a target to look at 40 centimeters, you're using some accommodative convergence, right? So, but no more than that. And it was not meant to create any accommodative demand more so than, let's say, a reading therapist would create doing reading therapy. And we tried to minimize saccades and pursuits, but if you think about it, it's a challenge to create a placebo that doesn't stimulate saccades, pursuits, accommodation of vergence. We did the best we could. We used the same procedures that we used previously in our other 2 CIT studies. So we thought this would be, would work. We really believed it would work. And then we followed the kids every 4 weeks, 4 weeks, 8 weeks, 12 weeks, and 16 weeks. And we monitored their progress. And 16 weeks later, we did an outcome evaluation where we repeated everything we did at the very first evaluation. All the outcome testing was done by masked examiners. So the kids and the parents did not know which group they were in, and the optometrists and the reading therapists did not know which groups they were in either. So everyone was masked. So this is absolutely necessary to create a situation where you have a low likelihood of bias. That's what randomized clinical trials are designed to do. And to the skeptics who've actually questioned the results of CITT and said, those guys, I don't believe the CITT results because they were biased. They were optometrists. They believed in vision therapy. They wanted the result to show that office-based vision therapy helped. They certainly can no longer say that, because we're the same group of folks that we really wanted VT to make a difference. But, we designed a good study. This was a quality study that had very low chance of any bias, high credibility, good quality. We had 100% follow-up for the kids in the placebo group, 96% follow-up in the kids in the office-based vision therapy group. We had, for all the VT sessions, over 4,200 visits for the study. We had a 97% show rate. So everything about the study was quality. In fact, I'm rewriting now the Cochrane collaboration systematic review. We're rewriting it. It's going to go. The new one's going to will be finished this year, sometimes in 2020, I believe, or maybe 2021. And this study, CITT-ART, is the only one that has perfect scores across the board in terms of no chance of bias. So that's the nature of the study.
I got to jump in. How did you do that? How did you get such great compliance for the research?
It's a credit to our fabulous study coordinators and enthusiastic investigators, the PI at each site, you know, the optometrists and all the investigators at each site. They all, you know, developing relationships with the families, and kind of like, you know, the way you do in private practice with your VT patients. You know how important it is to have your therapists not only be great therapists, but to have great interpersonal skills, and you know, to educate, you know, why we're doing this. So it's just a credit to the outstanding 120 investigators in the study. No one believed it could be done. In fact, the first time we submitted our grant, the original CITT grant, they said, you can't do this study. People are not going to show up for 12 weeks in a row. And we proved them wrong once, and we proved them wrong twice, and we proved them wrong 3 times. So we know we can do it. And, you know, we've learned how to motivate patients to come back.
I'm sorry, I interrupt you. So yeah, the results of the study.
Yeah, so the result is there are 2 parts to it. The first part, let me just speak about the clinical findings part, because this was a great opportunity for us to have a much larger sample size. If you remember the sample size from CITT, there really were just over 200 subjects, and there were 4 groups, so there were about 45, 50 in a group. That's not a big sample size. In this case, we had 200 in the vision therapy group and 100 in placebo group. So we had a much bigger sample size. And basically, we pretty much, with one exception, which we'll talk about, replicated the results. And we showed that vision therapy, office-based vision therapy, was statistically significantly more effective than placebo in improving positive fusion avergence and the near point of convergence. The outcome measure that we used was a combination of the 2. So we know that if you're an optometrist and you do VT on a patient, what do you look at after VT? You look at, well, are they no longer CIs? And how do we say they're no longer CIs? They have a normal near point of convergence. They have normal positive fusion avergence. So when you look at the combination, I think the numbers were 78% of the kids in the office-based vergence accommodative group met the success criteria for NPC and positive fusion avergence, versus about 29% in the placebo group. The problem with the outcome in this study versus CITT, in CITT, the symptoms also improved. There was a significant difference in symptoms between the office-based vision therapy group and the placebo group. In this study, unfortunately, there was not. Both groups improved significantly, more than 10 points, but the placebo group, the difference between the office-based VT group and the placebo group was not statistically significant. So that creates a problem for us, because although we can say that office-based vision therapy improved the clinical measures significantly better than placebo, we can't say the same thing for symptoms, although we certainly can say that symptoms improved. So the bottom line is symptoms improved, positive fusion avergence improved, NPC improved. So when we're writing for instance, in the Cochrane collaboration systematic review, our conclusion is going to be the same, that office-based vision therapy is more effective than placebo for treating CI. So it doesn't really change the total outcome. By the way, for some of you who have read it, there's an important argument that we present in the paper that you should look at carefully. We use something called the fragility index, which is another way of looking at results from a randomized clinical trial. And this is true for all randomized clinical trials. Many randomized clinical trials suffer from the following problem, and that is sometimes the difference between having a significant effect and no significant effect is like 1 or 2 patients, meeting the success criteria. So the fragility index is a measure of how robust the outcome is. So for instance, in CITT, the symptom outcome that I just mentioned, it turns out that 5 of the patients in the office-based therapy group, the real therapy group, scored 16, which means they were not successful. And none of the kids in the placebo group scored at that margin. So as it turns out, this fragility index tells us that if just 4 of those 5 had scored a half a point lower, 15.5 on the CISS rather than 16, we would have had a significant effect. So you see, even the negative effect we're finding there is very borderline and not robust. So keep that in mind when you're explaining this to others and patients. So that's in there, and you can read it. I think we presented that clearly. Now, so that's the good news. It's not all good news, but it's we show that VT works just like we did in CITT. The problem is when we looked at the primary outcome measure, reading, we did not find the primary outcome measure. You have to choose one. The term primary means you choose one outcome measure. So of all the reading tests, we chose the Wyatt 3 reading comprehension test. This is if you're not familiar with that, it's a test administered on a computer screen, and you read a paragraph, and then you answer questions. You read another paragraph, you answer questions. And that was the primary outcome measure. And it turns out that both groups improved more than you would expect for the 16-week period of time, right? 4 months. I mean, we do expect every child to show gains in reading, even if you do nothing, right? Just normal education. But I'm saying above and beyond what you would normally expect, both groups improved, but the kids in the placebo groups improved just exactly the same as the kids in the office-based vision therapy group. And that was pretty much across all of the reading measures. So we then said, I can't believe that. Did that really happen? Let's see, what else can we do? Are there some exploratory analyses we can do? So the first thing I thought of, I said, okay, well, let's just look at the VT group itself, and let's see how significant those changes were. So instead of looking between groups, you look within group changes. So you'll see in our paper, there's a couple of paragraphs about exploratory analysis within group. And sure enough, we found what I just mentioned, that even though the between group differences were not significant, within group it was a nice improvement in reading, more than you would expect. The next thing we looked at, next exploratory analysis, is I said to myself, you know what? Maybe we would see an effect if we separated out the kids in the group of kids that got better. The 78% that improved NPC and positive fusion avergence. But unfortunately, no, that did not yield any significant difference between the two groups. So we tried, and then the third one, and I'm not even sure this one is in the paper. I'd have to look again. But we said to ourselves as a group, what else could we look at? And we said, well, maybe if we separate out the kids who had reading problems, because Ben, here's an important thing for the listeners to understand. We had readers across the entire spectrum. Some were at the mean, or at the 50th percentile in reading. Some were at the 25th percentile in reading. Some were at the 90th percentile in reading. So I think listeners would argue and say, you know what? The problem is, how can you expect someone who's reading at the 90th percentile to show any improvement after 16 weeks?
Sure.
And I'll tell you, if you ask me later and want to know why we did that, I'll tell you why. But so we said, okay, let's separate out the really good readers, and then let's just look at the people that scored below the 50th percentile, the kids with reading problems. And unfortunately, that did not change the pattern. I was hoping for that at least. So I was hoping that one of those two analyses, let's just look at the ones that scored, that did well in VT, not the failures, the successes. And then the kids who had poor reading to start off with, they had more room for growth. I mean, there's a ceiling. If here's a, if you're just right below the ceiling, there's not any room for growth, and you're not going to see it. So that's really the what I can think of right now from the global question you asked about the results.
So many questions, so many questions. I just thank you for that great summary that you put forward. So, like you said, no difference between placebo and the treatment group. Do you have some theories as to why that was?
Yeah, of course we've been thinking about this. I had about 2 years where I would say about 1 year where I was the only one who knew the results, and my statistician, I couldn't even share it with anyone else. And I agonized this, it affected my sleep for about a year. And then we agonized as a group for a year. And, of course, the first thing that comes to mind, and I think the listeners will probably are already thinking this if they haven't thought about it before, they're going to say, well, you had a good intentions maybe in terms of the design, but you made a mistake because you didn't compare office-based vision therapy to sham therapy. You compared two different types of office-based vision therapy. You compared office-based vision therapy that stressed vergence and accommodation, and you had another type of office-based vision therapy that stressed maybe more attention, concentration, and maybe to some extent eye movements. And most optometrists would argue that vision therapy involves improving attention and concentration. And since we couldn't control that, after all, we did bring the child in and they would have to look at something, here's just an example of one of the placebo techniques. So since we're talking about that, we all know what a traneglyph looks like. You got the red sheet and the green sheet. You got the red-green glasses. Normally, we put the red-green glasses on and you separate them, and you're doing fusional vergence work, right? Well, for placebo, we took away the red one and we just used the green one. And they would just have the glasses, and we'd pop out one of the lenses. But it looked to them like, what do they know from VT, right? The kid doesn't know, the parent doesn't know. They're putting on these crazy glasses, they're looking at these interesting targets. That must be VT. And in fact, just if anyone's questioning that, 87% of the kids in the real VT group thought they got real VT.
It's amazing.
13% thought they got placebo. And 73% of the kids in the placebo therapy thought they got real VT. So we fooled them. So that was not the issue. If someone questions that, we don't think the kids knew they were in placebo therapy. But anyway, we'd have the child. Oh, sorry about that. Okay.
This is great that you're explaining this, because I think that a lot of people have questions about this placebo therapy. What did it look like? What was it?
And so let's talk about that training. So this would go on for about 5-6 minutes, where the therapist would say, okay, you see the faces on the traneglyph. I want you to take the pointer and point to the ones that have smiley faces, and then find the ones that are sad and trace it. And now count how many of this, and questions like that. So the therapist, just like when you work with a clown vectogram, you have a certain set of questions you ask. Point to the fox, or show me the block. How many blocks have an F on it? Those kind of things. So the same kind of questions. So in reality, they had to keep the target clear, right? It had to be in focus, but it's just 40 centimeters, no lenses. And they had to find things. They had to search. So it was a search technique. Another technique would be reading a visual acuity chart placed at 4 meters and just reading it from top to bottom slowly. and then going from the bottom to top, and then doing it with the right eye, and then doing it with the left eye. So that's an example. We had one where let's picture trial frames with two Maddox rods, one red and one white. So they're not going to be fusible. And there's a prism to disparate that. So we don't want it to fuse. We want it to be double. We say, do you see the two lines? Okay, now put your fingers on them, and your job is to rotate them until they're perfectly up and down, and then go back, and then we misalign them. And we said the better your eyes are working together, the more quickly you're going to be able to do that. Things like that. And we'd say things, during the traneglyph, we'd say, okay, does that feel like it's getting bigger or smaller? We'd use the same kind of lingo that we use as therapists. What does it feel like? Does that hurt? Do you feel the strain in your eyes? And things like that. What else? There's a flipper task. So we use a flippers, but instead of having plus or minus lenses, we had one base in on top and one base out on the bottom. And we'd have them looking at a traneglyph, and we'd have to say, okay, after we flip, find this, after we flip, find that. So they looked like we were doing accommodative facility training. So with that in mind, we felt that we were not doing any vergence accommodative therapy. And the hypothesis was that treating CI is primarily, not all, but primarily about improving fusion of vergence, accommodative amplitude, let's say, accommodative facility, vergence facility. And if we didn't do those things, we'd be able to separate out those two groups. Now, I know my philosophy of doing VT differs a bit from some others. I don't do a lot of movement techniques in my therapy. If I'm treating CI, it's mostly vergence accommodative therapy. I do start out, of course, the accommodative therapy is monocular to start out with, and that's the way we did it in the study. But I don't do a lot of, I don't do a lot of saccadic eye movement therapy and pursuit therapy initially, unless I find that to be problematic. If that comes out normal, I don't do that. But I know a lot of optometrists do a lot of more preliminary type work that stresses attention and concentration. So one major argument that people could have, skeptics about our result, they would argue that we made a mistake, and that is the therapy. We compared two types of therapy, and if anything, it would have been, and one of my regrets, and if you ask me later, what would I do if you gave me a do-over, is I would have a third group of no treatment at all. And then I could separate out some of these things. I could separate out the placebo effect if I had a group that didn't get anything at all. But we didn't do that. I mean, one of the reasons we didn't do it is this was about a $10 million study with 310 subjects. If I needed another 150 subjects, another 100 subjects, the price tag goes up, and you're not going to get funded. So these are things you have to think about that prevented us from doing what we wanted to do. The other thing we've thought about a lot, Ben, is there's something called the, what's the term? Oh, it's called response bias, where a participant in a study like this really wants to please the researcher. So it's not really placebo so much. It's, I'm spending 16 hours with Alice, the therapist, or John, the therapist. And, we have this great relationship. And in fact, I'm sorry the study's coming to an end. I'm going to miss my therapist. And I want to do my best at this follow-up. I want to make sure that they're going to be happy with me. So I know, I can kind of guess I got to read better. That's what the study's all about. I got to pay attention better. So I'm going to really do my best because, John worked so hard with me, and I want to do my best. So that's called response bias. And, this attachment that you form with a therapist, and of course the good old placebo effect. I mean, there obviously was a placebo effect as well. And by the way, the placebo effect tends to be strongest when you have elaborate protocols like we have in this study. If you're doing a study and all you have to do is take either the placebo drug or the regular drug and come in, a month later, there's a placebo effect, but you don't have this attachment to the therapist. You don't have all these visits. You're not spending hours and hours. in a study that's this elaborate, you usually get, it's not unusual to get a stronger placebo effect. The problem is we got an effect above and beyond the placebo effect that equaled the effect we got from vision therapy. So I think those are the main things we've thought of. I'm sure when you may have a couple of other thoughts, and listeners may have a couple of other thoughts about where we went wrong with the study.
I'm very interested to know the reading expert. She was so sure that this wasn't going to work. So what was her reasoning as to why we weren't going to see the effect?
Yeah, that's a great question. Her reasoning goes as follows. She says, I've been doing reading therapy and reading research for 30 years. We've researched just about any new idea about how, this reading program, that reading program. And no matter what we do, it doesn't happen that fast. You don't get these kind of changes in 3 to 6 months. You're working with kids who have developed a negativity about reading. They don't like it. It makes them feel bad. It makes them feel stupid because they can't read fluently. They avoid it, and by avoiding it, it compounds the problem because now you're not reading and your vocabulary is not improving. And you're falling further and further behind your good readers. So, in her experience, there was hardly anything she could think of in her experience that could make such a difference in only 12, 16 weeks. And she didn't see, and she didn't think that particularly if the therapy did not involve reading itself, actually directly work
Sure.
reading, how this indirect therapy could do that. And in her experience, it was just impossible. We were asking the impossible.
So she had to have been surprised that both treatment groups, I mean, the placebo and the treatment group, both saw an improvement.
Yes.
What did she think about that?
Yeah, I mean that did surprise her. The magnitude of the improvements were greater than she expected. We talk about effect sizes to try to determine if a result in a clinical trial is clinically meaningful versus just being statistically significant. You sometimes look at the effect. It's called the Cohen's d statistic, and some of our effect sizes were 0.7, 0.8, which are considered to be large effects. So, yeah, she was surprised by that.
Going back to that kind of magnitude question, do you have any idea of the amount of increase that these two groups saw? How long that typically would take a child to get, rather than just a 12-week period or 16-week period?
No, I don't have a number I can give you for that. I can just give you the numbers like I mentioned. Cohen's d stat, if you get a 0.3 effect, that's considered a low effect. 0.5, 0.6 is considered a moderate effect, and 0.8 is considered a large effect. And I'm just looking at table 6 in the study on my computer, and like with the the primary outcome measure, reading comprehension, the effect size was 0.65 in the VT group and 0.7 in the placebo group. And, we had other effect sizes, 0.8. We had one but in that same, for that oral reading fluency, it was 0.8 for VT, but 1.1 in the placebo group. So amazingly, the effect sizes were at least as strong in the placebo group or stronger. So it really makes all of this, unless we accept. So unless the bottom line is we had two types of VT, and it turns out VT without vergence accommodative therapy is just as effective as vergence accommodative therapy, then we don't have we can't really talk about VT helping. So I'm sure some of the listeners, some of the readers of this paper will, that's going to be their conclusion, the way they interpret this. And, every reader has the right to interpret it based on his or her experiences. In my opinion, Ben, I'm not a strong advocate of that. In my gut, watching the kids go through this VT, I'm not sure that I buy that, that this was another form of VT, but I may be in the minority of that. Most of my co-investigators are with me with that, but there are some who did the VT and said, you know what, I think we were doing something there. So that we're not going to know we're not going to know the answer until it would take another study to really answer that question.
I would think that members of your team or other people that have looked at this would say, wow, they weren't working on reading, and yet they saw such a huge improvement. Let's answer that question. What is it that we can do to get this kind of an improvement? So is it visual attention that we need to be working on, concentration, like you're saying? That's one of the things that strikes me from this.
Yeah, so I don't know how to answer that. It's all speculation.
Sure.
What I don't see in my mind, we didn't do any more. We probably did a little bit less than you would expect from a reading teacher sitting with a student doing reading remediation therapy, where they're saying, I want you to, okay, you got to keep the words clear, read them, go left to right. Now answer some questions, jump to the next page. When a kid's working with a reading therapist, they're doing saccadic eye movements, left to right,
Sure.
going back. They're looking at the next page. They're answering questions. Maybe they're flipping pages. They're maybe looking up at a chalkboard and coming back down. They're concentrating and attending for 45 minutes with this reading therapist. I think that's more VT-ish than what we were doing. One of the things I had scheduled to do at COVD, I had about 5, maybe 8 minutes of video just showing I taped the placebo video, so the COVD members at the talk could see what the placebo therapy is like. And I thought maybe by showing them that, they would be more likely to agree with me that maybe it wasn't real VT, but I'm not sure, because everyone has their own bias about this. My feeling is when I present this at COVD, most, a large majority of COVD members might think, you were doing VT, Mitch. That wasn't placebo. So that argument will now go on for perpetuity.
Hey, that's right. Dr. Scheimann, I've taken a lot more time than I had even initially thought we would. It's just such an interesting topic. I want to be sensitive to your time. Do you have a little bit more time?
Hey, I've got all the time in the world. I'm working now, so I love to talk about this. I have no limit. I'll probably get hungry about 5 o'clock. Now, so.
Well, good.
I'm ready.
Then I can ask some more questions, because I've got some questions that I still.
Yeah.
What unanswered? You kind of alluded to some, but do you have any unanswered questions that you still feel like you want to know?
Yeah, it's like what I mentioned before. If I could do this over again, knowing what I do now and whatever mistakes we made, I would do some things differently. I would find a way to look at the younger age group. That's where Carolyn Denton, our reading specialist, says what you really need to do is, because when you look at a first grader and a second grader and a third grader, those are the kids who, with proper remediation, and if you can just get them to be comfortable and asymptomatic, no longer have CI symptoms, that's where you can make the change. Once they even get into 5th, 6th, 7th grade, it's too late. They already have this negative attitude. The first, second grader, they want to be readers, but they can't because they have double vision and eye strain and headaches. If you can change, if you can impact their lives at that stage, that's where we're going to see the change. So that was our big mistake. And thinking about it, the only reason we did that It wasn't because of the reading measures. We can measure reading and attention at 6, 7, 8-year-olds, right? We can do that, but we couldn't measure symptoms. But it turns out that was really silly, because the CISS turns out to be a thorn on our side anyway. And we shouldn't have even, if I ever do a study again, it will not use the CISS. I will never use that again. I think that it has too many problems associated with it. So we should have said, we don't care about, we have to come up with another way to measure symptoms in younger kids, a different way of doing it. And we have to, so we need the next study, if anyone's going to do the next study, it's got to be 6, 7, 8, 9-year-olds, 6 to 9, because that's where you can get the effect. And in addition to that, we want to more carefully exclude the good readers. We want to exclude the ones. And here's the reason why we didn't do that, Ben. If we did that, we'd still be recruiting right now, because it's very hard to find just the kids who have poor reading. So, you're excluding this one and you're excluding that one. And before you know it, it's going to take you 5, 10 years to recruit 300 patients. And the other problem with what I'm saying, if you just think about it, is we would then only be able to say, if you have a young child who's between 6 and 9 and is reading 1 standard deviation below the mean, that's the one that VT is going to be effective for. But the others, all we're going to try to do is get rid of the CI. We don't expect any improvement in reading. So, but nevertheless, I would go younger. I would lean towards more kids with the reading problem, and I would have a no treatment group, just a natural history group. And I don't know. I mean, it would be interesting if some of your listeners to just do the following exercise, and for you to do it as well. I don't know if I mentioned this before to you. Okay, so you think that our sham therapy wasn't sham therapy. I want you to write down the 16 hours, what you would do for 16 hours with to create placebo therapy that would be less VT-like than what we did. I challenge any of your listeners to do that.
Absolutely. I mean, that's one of the things that I've thought was remarkable, is that you were even able to come up with some kind of a sham therapy. So hats off to you for that. What's been the feedback from both those within our community and those outside the community?
I'm kind of shocked, Ben, because there's almost been no reaction to it that I've heard personally. It's been astounding to me. It's like, was this even actually published? So I haven't seen, no one's throwing eggs and tomatoes at me yet, but I haven't been to COVD yet, where that might happen. But I haven't had, there were no letters to the editor. It could have been. The optometry press barely picked it up. Like I get this AOA report every morning, medication. They didn't even pick it up. I think one of the magazines interviewed me very briefly, but other than that, there's been very little. I haven't heard anything from the ophthalmology world. I've been at the PDIG meeting down in Florida, where you have about 100 pediatric ophthalmologists in the room with about 60 optometrists, and none of them, it didn't come up at all in that meeting. No one said, Mitch, I told you so, anything like that. Now, I suspect we're going to see something soon. I'm just waiting for the shoe to fall. I expect the next American Academy of Pediatric and, the joint to use that to their advantage. So I expect that to happen. But other than that, I haven't, quite frankly, Ben, I haven't pushed it. I've been trying to stay in hibernation as much as possible. Because, it's a problematic result for us. I mean, the way I deal with it at this point is I say, you know what, this outcome, if you think about it, is really not that different than what our political organizations have been saying for years. The Academy of Optometry, the AOA, if you look at the practice guidelines, much of what COVD says, most optometrists in private practice, I think we try to be careful not to promise too much. We tell them, I've got a pretty good feeling, and we have good clinical evidence today that we can take this condition and improve it. We can work with you and your child, and we can get rid of the convergence insufficiency. We can make you more comfortable. The rest is going to be up to you. If you don't go back and start reading, you're not going to be a better reader. I don't think many of us make a very strong guarantee that, if you just do vision therapy for the next 4 to 6 months, you're going to be reading dramatically better. Not just will you feel
Right.
better. I think we're careful about that. And if you look at the AAO, I think Stacy Coulter was the primary author on this. Lenny Press was part of it. We had a paper called The Struggling Student. And if you look at that, if you go online and look at The Struggling Student from the Academy of Optometry, you'll see that's exactly what it says. Vision therapy, and this is what we've always argued with the ophthalmologists, right? We're not saying that vision therapy treats dyslexia, that vision therapy treats learning problems. No, vision therapy is designed to treat vision problems. We can do that. We have evidence that we can do that. The CITT-ART reinforces that with a larger sample group. We've shown we can improve near-point convergence and positive fusion aversions. Vision therapy works. And then the rest is up to the reading therapist and the teacher and the kid and the parents to get because if the kid's still not going to read after years of disappointment, they're not going to be better readers. So, when you look at it, you step back a little bit, and that's what I've had to do personally to be able to sleep again. That's the way I rationalize this whole thing. The outcome is not what I expected it to be. I hoped for a different outcome, but when you look at it, the bigger picture, it's really reinforcing the argument we've always made against pediatric ophthalmology and pediatricians. We're not saying, and to some extent, this might actually be a good thing because it's supporting that and saying, okay, this is where we're going to draw the line. VT works. You need to go back to school and get reading comprehension, but it's going to be easier for you. You're going to feel more comfortable. And if you really go back and you can give the effort, you're not going to be uncomfortable. You have an hour to work with a reading therapist. You're going to have a good hour, and you're not going to be uncomfortable after 15 minutes like it used to be. And now you're going to be a better reader because of that.
You went right to one of the main takeaways that I had from this research. For someone that has been working really hard to get coverage from medical insurance carriers for vision therapy, so many of them waive that, the AAPOS statement saying that this is controversial, that there's no study. Finally, I could say, yes, I've been agreeing with that. And here's a paper to show that we do agree with that. This is a medical condition, and we're treat it with a proven medical treatment, which we can still say with the CITT-ART.
Yeah, exactly, Ben. I think that, that's exactly what it shows. And in fact, we now have, because the sample size was larger, we have a much stronger, when you see the Cochrane collaboration systematic review coming out, you'll see we're able to make even stronger statements than before, showing that, this is a medical treatment. And from a medical standpoint and insurance reimbursement standpoint, there's every reason to reimburse this. And really, we're not looking at reading. That's not, it's treating the medical condition.
Dr. Scheimann, you might find this maybe interesting to hear, but for me, this interview has been really great. For someone that hasn't known you personally, has just seen you from afar and seen this great researcher, I think it's easy to think, wow, this Dr. Scheimann, he's a science guy, a researcher. He didn't necessarily have his heart one way or the other but to, and so we got the outcome that we did. To hear the disappointment and the struggle that you personally have had with this, I think reinforces the great research that this is and how much you were involved in and just tied to the success and making sure this was a good balanced study.
Yeah, thanks, Ben. I appreciate that. The only thing that someone can do in my position, a study chair or a PI, the only thing we can do, our job is to create good science by using techniques that minimize bias, randomization, a good protocol, making sure all the investigators follow the protocol, good retention, good recruitment, and mass examinations and all that. And the rest is, just happens. And even so, that's what enables someone like me who quite frankly, did have a certain expectation of what the result would be. That's what allows me to do this and still do it in a way where it's credible science with low risk of bias. That's the whole nature, and that's why it's good for listeners to understand that that's the reason why scientists stress the importance of RCTs. That someone who has a bias like me and led the study could still end up with an outcome that is totally regrettable from my standpoint. And so, yeah, all that is true.
So where to from here? Not only for you personally, but where do you see the research, the future research for vision therapy? Where do we need to go?
Well, we're just looking at the tip of the iceberg. There are so many other conditions, and even within CI, I mean, many more questions. We don't know much about treating CI in the adult population, in the young adult population. We don't know about treating CI in the presbyopic population, and there are other conditions, convergence excess, all the accommodative conditions, oculomotor deficits. So I don't know who's going to do it. I've pretty much run out of time. I don't. I'm hoping one of the things that I'm most proud of is as a result of these randomized clinical trials, we've developed a whole group of young, properly trained scientists in optometry who can do these things, and I'm expecting them. I'm expecting the 40, 50-year-old, 30, 40, 50-year-old PIs from the different studies to carry the flag now and start answering these other questions. My own personal research interest now is moving into concussion, CIN concussion. Natural to move into that because the kids, the same age group, you all know, all the listeners are working with these kids now. After concussion, what do you find? CI and AI. And but it seems to be a different condition. They're more symptomatic. It's more complex and just a fascinating area. So we've already submitted 3 randomized clinical trials to various agencies to get funded to do a randomized clinical trial looking at VT for concussion-related CIs. We've not been funded for any of them yet, but the applications we're going to keep doing it until we get funded. And so that's where I'm moving in at this point. So I'm moving out of routine VT and leaving that up to others, hopefully. And although I am working with intermittent exotropia now in a different, we're doing a randomized clinical trial with intermittent exotropia, a pilot. So those are my 2 areas. I'm looking at intermittent exotropia and concussion-related vision disorders.
Well, I look forward to our next interview where we get to talk about those topics as well, because those are both, I think, very interesting, not only to me, but to many of us out that are watching this. I want to personally say how grateful for us young, well, I can't necessarily say young doc anymore, but younger doc, how grateful we are for the research that you've done, how much you've dedicated yourself to this, and I think we will be forever indebted to the great work that you've done, Dr. Scheimann.
Great. Thanks so much, Ben. It's been great talking to you today.
Thanks. Great interview. I mean, you're naturally just amazing.
Great. I'm glad it went well. I enjoyed it.
Great. So there's going to be some editing and some other things. I'm guessing we'll probably put it out in about a month or so.
Okay. That'd be great. All right.
And was there anything that you wish was different or you want me to take out or anything like that?
No,
I didn't
really.
feel like it. Yeah.
Yeah.
Okay.
Great.
I'm gonna have to. I probably am going to release a full version and then a cut version, just so that people that don't have an hour and a half
Yeah.
can watch it too. But
Good.
all right. Well, thanks again.
Take care.
You too. Bye bye.
Goodbye.
That went well, though.
What, Max?
That went well.
Yeah. Let me shut it down. Yeah, much longer than